as I said, was not on the schedule initially, so I'll try and be brief. So we all know what a supracondylar fracture is. I'll just run through it quickly. Extension type, you get a 98% deficits. It's very difficult in crying children with anxious parents, but it has to be done. So this is the easiest sign that you can make a child do. It's the okay sign. If this is done, then you know that all three nerves are working well. And then we know that nerve injuries occur radial in posteromedial displacement, and the medial nerve in a posterolateral displacement are the most often affected. How do we manage these very obviously displaced fractures? Okay, casting, not an option, used to be done earlier, nowadays no one does it. Close reduction and casting, again you require hyperflexion. Remember that these fractures in the acute stage will reduce very easily, okay, but you cannot hold it. You can get a vascular compromise because of the hyperflexion. The reduction is unstable. And then traction followed by casting, again not an option in acute fracture. Close reduction and pinning, open reduction and pinning in irreducible fractures. Close reduction and pinning remains the gold standard. So how do we manage them? You have the cross pins, you have the divergent pins, and then you have the parallelly placed pins. Biomechanically, we all know that the cross pins are the most stable. And off late there's been a tendency towards the three lateral pins, which are supposed to be equally stable as the cross pins. This is the positioning. I think all of us know that. You hyperflex it, strap it, or you don't need to strap it, and then pin it using fluoroscopic control in AP and lateral planes. So two pins are inserted in the hyperflex, two pins or one pin. And then you extend the elbow a little bit. This is how I do it. When you want to put a cross pin, I always expose the ulnar nerve on the medial side through a small incision, and then put the wire anterior to the ulnar nerve. And then the medial wire is pinned, keeping the nerve retracted. So it's very safe. In all these years, I've never had an ulnar nerve problem. And then you can, once you pin them, the slab can be put, the POP can be put in 90 degrees or even less than 90 degrees. It is stable. Then this is the same patient, pinned 3 weeks post-op and 3 years post-op with absolutely no residual deformity. This is another 8-year-old child with this gross displaced type 3 fracture, again pinned with cross pins. Reduction is good. 3 weeks post-op, heals well. 1 year post-op, no residual problems. This is another case with a very badly displaced 3 lateral pins. Goes on to heal well with no residual deformity. Coming to the flexion supracondylar, management is similar to the extension type. Type 1 treated by simple immobilization, type 2 close reduction pinning, type 3 closed or open reduction and pinning, but remember in a type 3 flexion type, be ready to open. It's much more common to open rather than in the extension types. This is a 7-year-old kid. This is the classical displacement to the valgus displacement in a flexion. And then the lateral X-ray shows you the distal fragment anterior to the proximal fragment. Treatment: open reduction, K-wire fixation. I had to use 2 incisions, and then goes on to heal well. What are the complications? Inadequately treated ones, iatrogenic, you'll get cubitus varus. Vascular, including Volkmann's. You have the 3 types. Pink pulsatile hand, of course, is obviously great. Pink pulseless hand is also acceptable. And then you have the white pulseless hand, where you got to go in and do something, release the compartment, maybe even explore the artery. Neurological deficits, 12% in all series. We know the radial and the median in extension type, and in the flexion type, it's the ulnar nerve which is more commonly involved. And you get growth arrest in very distal supracondylar fractures. These are not distal humeral epiphyseal injuries, but just plain simple distal supracondylar fractures where you can still get a growth arrest, and avian of the trochlea. I'll just show you one. This is a 3-year-old with a type 3. This was pinned again with what looked like acceptable pinning, but in the post-op X-ray, this is what happened. There was complete loss of reduction. And why did that happen? This is iatrogenic. Sorry, the pins were all crossing below the fracture line. So you have to make sure that when you use cross pins, they have to either cross at the fracture site or above the fracture site. Then it had repinning done and then went on to do well. Avascular necrosis of the trochlea, because the arterial vessels pass through the physeal plate, enter posterior to the lateral condyle, and disruption of these vessels may lead to AVN. It can occur despite treatment. So when you have a distal supracondylar fracture, warn the parents about it. And of course, in epiphyseal injuries, it's more common. So this was the fishtail deformity, and sometimes you can get an AVN of the entire trochlea and the adjacent metaphysis. Distal supracondylar fracture, pinned, internal fixation was done. you can clearly see that there is malrotation here. If in the lateral you see the spike anteriorly in the proximal fragment, that means the reduction is not correct, it is rotated. So anyway, 1 year, 6 months later, you have cubitus varus. This is all our own cases. Corrective osteotomy was done, and then 5 months post-op, you can see there is a sloping trochlea. Slowly it is going into an arrest, and this is at 14 years of age. It's a complete disaster. The avian of the trochlea, medial subluxation of the ulna and radius, and a malformed radial head. So you have to be aware that in distal supracondylar fractures, these things can happen. And then this is just an arthrogram showing that nothing could be done. We just left her alone at this stage. In conclusion, just stick on to the type 3 fractures require urgent reduction. Stabilization is either by 3 lateral or cross pins is a must. Close reduction and pinning is ideal. And open reduction when necessary should not be delayed. Don't hesitate to open. Do not try and reduce multiple times. Okay, at the most twice, thrice try a close reduction. If you can't get it, be ready to open. Thank you very much.
And I now invite all the speakers for a panel discussion. And any questions to the speakers, you are now free to ask.
How much of the real spike is acceptable? So, like Dr. Sargun showed, absolutely acceptable.
Yeah, you should try and get little bit of a spike is okay, but if you see a gross anterior spike, then you know it's malrotated and it's not. Yeah, so a little bit is acceptable because you have shoulder rotation to compensate.
Because we are asking it like that, if it is there, whether we should open it or accept it. It is the question is that whether we should
You should
open it or open it and reduce it properly.
You should ideally open it and reduce it. You should try not to have any spike.
So, from your initial accident, there was spike.
Yeah.
Did you get the
No.
Secondly, when you said you hyperflex it,
Yeah.
hyperflex it and tie a band around it, whether you do pronation like this?
Yeah, sorry, I didn't mention that. All supracondylar fractures, I follow what Dr. K. Wilkins taught us. I pronate it. Whether it is posterior medial or posterior lateral, I keep it pronated. Yeah.
Okay, one question I would like to ask. Till how late would you perform close reduction pinning in a supracondylar fracture?
Yeah, we had this debate 3 weeks ago.
Okay.
Okay. See, definitely up to a week, it can be done. Okay. It's the beyond 2 weeks, we all know we leave it alone. Okay. Allow it to malunite. At least that's what I do. Allow it to malunite. You can always do a supracondylar corrective osteotomy later on. It's the children who come between 1 week and 2 weeks, which are in that gray zone. Okay. I think I would still prefer to leave it. John tends to fix them.
Yeah, I think up to 10 days we've been able to get close reduction sometimes. It's surprising that not all of them are united at 10 days. So we've been able to achieve close reduction, but even up to 3 weeks, if it's a significantly displaced fracture, I would tend to do an open reduction rather than just leave it. But I think that there's really no literature to support this as yet. I don't know. No guidelines and no this thing, but. And I mean, it's anecdotal, so I don't think I can go beyond. But I think, see, if it's really displaced, I think if it's minimally displaced, I tend to go, because then you can always correct it with an osteotomy. If it's grossly displaced, in spite of any osteotomy you do, you never really get a good-looking elbow. I mean, we must have done how many of these osteotomies, and the ones which are really badly deformed, in spite of all the various techniques, there's still some ugly sort of bump in the elbow which remains. I don't know what's the experience with other people here. I think myositis is slightly over. I think it happens if you're either too aggressive with your surgery or there's been some previous sort of manipulation, too much manipulation, massage, etc. I think if you're really careful with your dissection, myositis should not be a problem. Okay, so I kind of strongly believe in that, but I don't, yeah.
you pass your pain from lateral first or from medial?
From the lateral side first, always.
No, what I do, I'm telling you, if it is displaced laterally and there is a combination on medial side, if you try to push from lateral side, it's fine, it's going to stay. If it is displaced medially, then you try to push your wire from medial first. That gives you a stable reduction and it stays there. Yeah. telling from my experience of more than 60 or 70 supracondylers. If it is displaced laterally, you pass your wire from lateral first. And if it is displaced medially, because what happens if you try to push from the other side, you tend to push it further on that side.
I think,
I always put the medial pin first, whether displacement is
okay.
A reason is because
No, but there's only one thing. I mean, I don't know. I think there's one situation where the medial pin probably makes sense first is where you have a very oblique fracture, which is going distally on the lateral side. And then you have a much bigger segment on the medial side. And there I think it makes sense to put a medial pin. The problem with putting the medial first is then you have to keep it in that flex position when you're passing. So then you need to make sure you identify the nerve and then do it.
So the easy thing is when you put a lateral pin first or two lateral pins first, as John said, you can extend the elbow slightly. The ulnar nerve is going to fall backwards. You can easily make that small incision, see the nerve and pass the pin, or even milk it and do it. That is one great advantage of passing the pins laterally. Nowadays I tend to do more and more lateral pins only. So there's no question of the medial pin at all, whatever the fracture configuration is.
Now let me,
Three lateral.
let me give you a counter argument on that. Most people have an internal rotation deformity at the supracondylar fracture. When you reduce the supracondylar fracture under an image and you externally rotate, you get a locked reduction and you get a proper lateral view. So then you have the medial epicondyle right in front of you. You can feel the nerve and you can place your pin and drill it in under image. So you know the exact plane where the pin is going in, right? Then this whole situation becomes stable. Lateral is a big broad area. You can tie a blindfold and put it in. But it's the medial pin which is critical, and this position will always give you that first critical pin going in, and then this. I've always done it this way. I've always done it.
Okay, I think we are running out of time.
only lateral pin put in.
Yes, but that's sensible because medial pins cause ulnar nerve problems.
I think we have run out of time. We'll move on with the next session.
Okay.
You can ask your questions to the delegates outside. Thank you so much.
Thank you, Sandeep, for conducting that. Thanks for conducting the POSI 2014 in Chennai, which is the man to contact, and 2015 in Delhi. So that's for your information, Dr. Vijaya.
Thank you, Dr. Shah. I'm speaking actually on fracture shaft femur in children. More emphasis on tense nail, of course, because that's current. Remember what Dr. Blount said many years ago, fractures in children are different. I know I'm speaking to a general authority. Diagnosis is usually obvious. Always look for associated injuries because these are high velocity injuries, intra-abdominal, intrathoracic, head injuries. Isolated fractures rarely cause hypotension. So if you have a child in shock, look for other injuries. Look for ipsilateral fractures. Again, this can be missed very easily. Fracture neck, distal physeal injuries, etc. In children less than 36 months, always look for signs of child abuse. It's not as uncommon as we think. It's actually more and more commonly diagnosed. This is a child, just showing an example, 39 days, came with fractures, multiple fractures in the lower limb, various stages of healing. Again, this was child abuse. And then they go on to heal. You can see the multiple fractures, various places, healing, usually metaphyseal. What do we look for in the x-rays? Level, pattern, whether there's comminution, associated injuries, whether it's traumatic or pathological. Traumatic are the ones you're going to deal with now. The different methods of treatment are dictated by patient's age, fracture characteristics, social situation of the family, very important in our country. And we know that in the past decade, the past 10 years or so, there's a trend away from non-surgical treatment of fracture shaft femur, and we now move on towards surgical stabilization. More and more fractures are getting fixed. A number of different options are available: elastic nails, rigid nails, and then the minimally invasive plating or the submuscular plating. Age groups: neonates and infants till 6 months, 6 months to 5 years, 5 years to 11 years, and then the 11 years to skeletal maturity. So these are the broad age groups we divide fracture shaft. Newborn fracture, I'll just briefly touch on them. Birth-related injuries, you can get them in twin pregnancies, breech presentation, fetal osteoporosis and prematurity are predisposing fractures. It's always a spiral fracture of the proximal femur with the proximal fragment flexed. Good news, there's thick periosteum and there's excellent remodeling potential. We do not look for anatomical reduction. Difficulty, they're very small children. Management: splinting, spica or a Pavlik harness. Most commonly used is the Pavlik harness. So this is a newborn fracture femur, again treated. And then you can see that even though it has healed like this, after 3 weeks it's that, and then they slowly remodel well. This is a classical spiral fracture, subtrochanteric region. This is in a Pavlik harness. This is the kind of healing which you will see. And then 1 month later, and then 6 months later, there's almost no evidence of a fracture. So they all remodel well. You can accept any amount of angulation as long as they heal. Complications almost none. If you put a spica, you can have skin problems. The 6 months to 5 years, the gold standard again still remains early spica traction. The pros, high success rate, low technology, no surgery. What are the cons of doing this treatment? You have to have nursing care, requires a family capable of managing a cast. Now this is quite important in our setup, and may require somebody to be off their work for a while. This is a 4-year-old child treated in a Thomas splint, went on to heal with angulation. This is at 2 months, but because the child is young, we know what will happen. 6 months later, and then they nicely remodel. So again, there's no real indication to go in and operate. 5 years to 11 years, what are the treatment modalities? TENS, submuscular plating, and the external fixation. What is currently in vogue though is the TENS nail. Okay, the other two have gone. So TENS, I'll just briefly, this is the armamentarium that you got to have. You have to have nails of all sizes ready. These are the tools. I think we all know it. I won't go into them. The cutter, the rod bender, and the F tool, which is extremely useful. Biomechanical principles, there's flexural stability. Then there's also translational stability. And there is rotary stability. So in all three planes, these nails, when inserted correctly, are stable. That's basically the message. 4 to 5 years though is a gray area. I'll just come back to that. You can treat them in early spica casting. You can treat them with traction in spica casting. You can do submuscular plating. You can do flexible intramedullary nailings. Some 4-year-old children can be really big. It's difficult to treat them in spica. The advantages of nailing, I've started nailing them, so short hospital stay, early mobilization, avoid complications like shortening and angulation, avoid hassles of POP care. What are the limiting factors of elastic nails? There are limiting factors, that is 11 years, or if the child is over 49 kgs, you cannot do a elastic nailing. Principles, you have to use pre-bent nails of equal diameter to achieve 3-point fixation. The opposing bending forces are equal. Avoid malalignment with varus or valgus malpositioning. Remember to bend them 3 times the diameter, and most importantly, do not bend them with your hand. You need a bender, like a French rod bender what we use in scoliosis. That's what you need to bend them, so that you bend them in the correct plane. Pre-op assessment of the nail size, you have to use the largest size which can be passed into the femur. They have to occupy 80% of the diameter of the canal at its narrowest level. So the usual calculation is 0.04, whatever into 0.04, that will be your size of the nail. You need a normal size radiograph. We are in the age of digital radiographs where everything is compressed. So remember to ask your technician to give you a normal size radiograph. It can be done even with digital radiographs. That's very, very important. Otherwise you're going to have the wrong size nail. Fluoroscopy table, of course. And it's either retrograde or an antigrade insertion, as the case may be. Sorry, it's not moving. Yeah. And then entry points medial laterally have to be at the same level on the femur. So that's the same level, 2.5 centimeters from the physeal line. You make an entry with an awl, and then you start inserting the nail. I'll just rush through this. This is not important. Nail is advanced, and then you advance the other nail up to the fracture, and then one of the nails is advanced across the fracture, and then the other is. Okay, so that's the way it's done. Cutting the nails, impacted nails in. And then we'll go through some examples. This is a 4-year-old with a fracture femur. There is more than 2 centimeters shortening. There's angulation treated with a TENS nail. You can see that the nails are divergent. They're most convex at the fracture site. So your pre-bending has to be accurate. You have to template it on the fracture and see that the maximum bend is at the fracture site. And then the medial nail goes in all the way up to the neck, and the lateral nail goes up to the greater trochanter. Okay, this is 6 weeks post-op, 18 months post-op. Before anybody asks me, I do not tend to remove these nails. Okay, so I just leave them in, nothing happens. This is another 6-year-old child, again bent. Even proximal fractures can be treated, subtrochanteric fracture. You can see that the bend is again at the fracture site, so the maximum bend. So this pre-bending is important in both in the AP and the lateral planes. 3 months post-op, it's all well healed. With an 8-year-old male, again treated. And then you can see that the results are very good with this kind of a treatment. What are the complications? You can have loss of reduction in length unstable fractures. What are length unstable fractures? Basically they are comminuted fractures like this. This is from Dr. K. Wilkins. So this is what was done. It collapsed. And then what should have been done was an external fixator. So when you have a length unstable fracture, this is my case. This is what the canal measured. I put in 2 mm nails. The butterfly fragment moved further. So I put a simple just fixator, maintain the length, and then they go on to do well. This is always, I do it on a regular table to check for rotation. You just check for rotation that is equal on both sides, and then they all go on to heal well. Complication, missed ipsilateral injuries. This is a child with a fracture shaft of femur, did a 10 nailing, missed the Salter-Harris type 5 fracture in the knee, ended up with a deformity of the knee and then had to have a lot of surgery. So that is the epiphyseal bar. Other complications, malrotation, you always check for it after pinning. Irritation from the nail ends, and sometimes you can get a procurvatum deformity. In 11 years to skeletal maturity, you have to have a rigid trochanteric entry nailing. You can do submuscular plating. You can use flexor intramedullary nails only if the child is less than 49 kgs. You never do a piriformis entry like an adult. Okay, that will lead to AVN. Remember, it is not an option. Treatment, this was a 13-year-old boy with a close fracture of the femur and the patella. He was treated elsewhere with an orthofix external fixator. Also had a screw fixation for the patella. 8 months later, he presented a deformity, shortening and a stiff knee. So this was his X-ray when he presented to me. The patella had healed, the femur had not. So I did a rigid intramedullary nailing through a trochanteric entry nail, and that has gone on to do well with no evidence of AVN even after 2 years. In conclusion, early spica and traction with spica casting is still effective in children up to 5 years of age. Flexible intramedullary nailing is an effective, relatively economical method of fixing femoral fractures in the 4 to 5 year and the 5 to 11 years age group. Rigid lateral entry lock nails preferable in the adolescents, and external fixators and submuscular plating useful in unstable fractures. Thank you very much.
Thank you, Dr. Vijay. Maybe just a couple of questions before we move on. Any questions?
Less than 1 year of age.
Spica,
With a gallows traction of
we don't use gallows anymore. It's just spica casting. Close reduction and spica, yeah.
as you said, any angulation is acceptable.
In the neonate, if it's beyond neonatal age, yeah, we try and get acceptable reduction.
What people newer concept coming up is strap this knee, this leg,
That,
this leg.
that is the old method, where you strap either to the abdomen or
That is
the
known
but
to-
that's not done anymore.
It is
It's
known
not
to
done.
cause a very high increase in the pressure.
You
the
can have
compartment
vascular
pressures.
problems, skin problems, it's not done anymore. Okay, there are a variety of what people do, many kinds of treatment, but what is usually done is, we use a knee brace, I don't know what you use. We use a knee brace for about 10 days to about 2 weeks. It's nothing to do with fracture stability or immobilize, just immobilize the knee to control the rotation for a little bit. Sometimes I put a slab if I don't have a knee brace ready. But again, the slab need not necessarily cover the fracture or go high up in the thigh. It's just immobilize the knee for about 10 days to 2 weeks, that's it.
Vijay, what is the single most important predictor for the use of a TENS in your, for example, experience? Is it the age of the patient, weight of the patient, or the fracture pattern?
No, it's the age of the patient.
So you'll use it for
Yeah.
age, because we tend to use it more for weight than age. I don't know what the house feels about it. So
Weight bearing after the fracture starts showing adequate callus, maybe in 4 weeks to 6 weeks.
Do you normally do it on the, hello? Excuse
Yes,
me.
sir.
Do you normally do it on the normal table?
Yeah, I do it on an ordinary translucent table, not on the fracture table.
And all age, even in adolescent age?
No, 5 to 11, 5 to 12, depending on the weight of the child.
And do you have any
Please,
difficulty in
please.
reducing it?
No, most of them in the acute stage will reduce quite easily. Otherwise, you have that F tool, which is actually very, very useful for reduction.
yes, the last question.
How many times you get difficulty in balancing diameter, same level, entry and same apex, curvature, everything, you get difficulty?
Sometimes it can be difficult, but what I do is, when I drill from the lateral side, I also drill the medial cortex. So I know that my level is the same, absolutely parallel to the physis, 2.5 centimeters. So I know my entry points are equal.
Every time you get same diameter nails or
Yeah.
you use?
No, I
unequal
use only
diameter
same
also?
diameter nails. Different diameters will cause varus or valgus.
Thank you, Vijay. So we'll now invite Dr. P.N. Gupta, who's going to speak on the use of fixators in gap non-unions of long bones. Dr. P.N. Gupta.
Good afternoon once again. This little problem with the computer. Actually, this was supposed to be a debate with Dr. Ramni.
Yeah, but you can carry on with your part.
So it would be a sort of ex-party decision now. Sort of ex-party decision.
Fair enough.
So
we give you the the ring to
basically
you.
fixators are biological options for gap non-union for long bones in children. So this is a small talk. Basically, bone defects in children could be post-traumatic or post-infective. So post-traumatic bone defects being uncommon because most of the trauma in children is actually low energy. High energy trauma in children is uncommon. So most of the defects what you see in children are basically post-infective. So the problems of a gap are basically a non-union gap, and frequently in a situation with osteomyelitis there is a very large bone defect. There could be associated limb shortening, a deformity because of the infection process per se or because of the growth plate involvement, and this growth plate involvement can cause further shortening and growth arrest, leading to either an angular deformity or a shortening or both. So basically the goal is to bridge the bone defect, to basically make the limb unite and make it functional, equalize the limb length, correct the deformity for a functional limb. The problems associated with biological reconstruction. Biological reconstruction means autograft, allograft, are poor local soft tissues, often associated limb shortening or an angular deformity like this. Limited graft availability, high donor site morbidity especially in children, and high failure rate with a gap of more than 5 centimeters. We all know that a gap of more than 5 centimeters, if you fill with autografts, it tends to get resorbed. The advantages of distraction osteogenesis are, it's a bone regeneration. You are not spending the original bone of the patient, so it can be used for a future purpose, and the bone regenerate formed is same as the original bone, and unlimited gap bridging filling is possible, and up to 20 centimeters of regenerate has been grown with distraction osteogenesis. Poor skin is not a deterrent. No donor site morbidity or availability problem, especially in a younger child. The availability of autograft is very, very limited, and no risk of viral transmission and no bone banking required as in case of allografts. So what's the literature evidence? There was a study from by Jan et al. And where they classified it to non-union with bone gap larger than 4 centimeter or less than 4 centimeter, and the ones which were less than 4 centimeters, they did well with the biological methods of reconstruction, that is bone grafting, but the recommendation was that distraction histogenesis is the preferred procedure for gap more than 4 centimeters of gap. And there are similar studies where Elizarov method was successfully used in infected non-union of tibia. Again, the study originated from Delhi. Some of my cases, and this is one such case where biological reconstruction possible with autograft. Perhaps one can think of stabilization of the fibula, but we did a debridement, and you can see we did a distraction osteogenesis with the Elizarov, and you can see the amount of bone growth obtained with a distraction osteogenesis. So one can actually think of a stabilization of fibula, but what I want to present here is that even in a difficult situation like this, a lot of bone growth is possible, and you can see the new bone formation is same as the original bone. A situation like this in a 12 years old girl with, you can see this femur which is approximately of the diameter of a fibula, And this is about more than 30 centimeters of shortening, about 10 in the, I think it was 8 in the tibia, and the rest of the thing was in the femur. So is a biological reconstruction possible and functional limb is possible with this sort of situation? Absolutely no. So what we did was Elizarov in this child, and you can see the region rate. This we gained about 18 centimeters of region rate in the femur, despite a small fragment. And I did a second stage lengthening and a plate fixation, and surprisingly I was not expecting any knee motion, but this is the end result. And this girl is actually now married, and she fractured her patella, and that was an undisplaced fracture. And we offered them surgery, but she refused, but eventually she did well. And what to do in this sort of situation with a poor local soft tissue? I almost advise them that this is a hopeless situation and this would end up in amputation, but we did a distraction osteogenesis, and this is the end result, though I don't expect any knee motion, but the fixator was removed at this stage, but X-ray was deliberately not taken at this stage to actually reduce the radiation exposure risk. This girl is now walking with a brace. And this is the literature for donor site morbidity, which says that the gait analysis of the donor leg and contralateral normal leg after resection of the fibula showed definite differences. So even the fibular graft harvesting is associated with some sort of gait abnormalities. And another study originated from Jamaica, which says that autogenous iliac crest bone grafting is definitely associated with significant complications. Another study that bone graft technology as bone grafting technology emerges, the known complications of current standard therapy should be weighted against the risk of alternate therapies. A study by Song et al. Shows that bone results and functional results vis-a-vis the distraction osteogenesis and the biological methods. With distraction osteogenesis, excellent result in 65% and excellent results in 35% respectively with biological reconstruction. So this is some of the additional literature. I will not go into the details of that, which is in favor of distraction osteogenesis. To summarize, the distraction osteogenesis actually has revolutionized the current practice of modern orthopedic surgery and is a procedure of choice for bone defects in children, especially large defects more than 4 to 5 centimeters, and more so with growth plate involvement with shortening and angular deformities. Thank you so much.
Thank you, Dr. Gupta. Just maybe a couple of questions, yes, sir?
Yes.
So you do the corticotomy and then you distract?
Yes, sir. It's actually a osteotomy, a complete osteotomy. Corticotomy is nowadays not done. It's a complete osteotomy with a latency of about 5 to 7 days. 5 days in children, and you can go up to 7 days depending on the local vascularity, or even more sometimes. So, and then you start distracting.
And you do it at both the ends, like in the first X-ray you showed that both the ends were very small.
I did it at the proximal end. Usually it's a unifocal, but you can do a bifocal depending on how much bone is available. Yeah, that's basically a bone transport. And the bone gap is filled by distraction osteogenesis. Yes.
So actually I'm not defending Ramani because he is not here.
Yeah.
So if he would have been here, he would have spoken differently about vascularized fibula. Your take on that?
Yeah, vascularized fibula, actually it's a good procedure. Only problem is it is available in only a limited number of centers.
Well, you just need a
you require a plastic surgeon most of the times.
You don't require a plastic surgeon. You require 7-0 proline and good hands. So I think that is all you require.
One is that it's not available. I am not talking of your center or my center, but
okay.
Average orthopedic center.
Sandeep wants to say something on that.
Dr. Gupta, hello.
Yeah.
I read that paper.
Yeah. Non-vascular.
Yes. That's in forearm fractures. That's in forearm fractures. Yes, I have read that paper.
The good thing about fibula is that fibula can fibula can even be used in an infective bed. And there's evidence on that as well. Anyway, very good. Thank you so much. So
Dr. Gupta,
last question, yeah.
Oh, that was for about 1 year initially when we gained about 1 year, when we gained 18 centimeters, and you can see the amount of shortening was 30 centimeters.
Yes, last question, sir.
Dr. Gupta, how much shortening, angulation and rotation is acceptable in femoral fracture, especially in the 5 to 11 age group?
Shortening,
Angulation and rotation in femoral shaft fractures.
rotation 5 to 11.
5 to 11.
I would put it as less than 8 years and more than 8 years. Less than 8 years, shortening acceptable is not more than 2 centimeters. I'm talking of a fresh fracture. And more than 8 years, shortening acceptable is not more than 1 or 1.5 or even more than 10 years, not more than a centimeter. It has been shown that the limb overgrows, but not more than a centimeter and a half. A centimeter and a half. And the amount of overgrowth which is there is depending on the shortening. If you have 1.5 centimeters of shortening, 1.5 centimeters will tend to overgrow. If you have 1 centimeter of shortening after a fracture union, it will 1 centimeter will overgrow. So before the growth spurt of 8 years, it's usually 2 centimeters. After the growth spurt of 8 years, it's usually not more than a centimeter. As regards to rotation, very little rotation is acceptable, maybe 5 to 10 degrees, but then the acceptability has to be from the patient side. There are patients who have been walking with gross rotational deformities as well, but I would not accept any sort of rotation. Maybe 5 degrees this way or that way may not make a big difference, but otherwise I will not accept a gross rotation.
Thank you, Dr. Gupta.
Angulation, sir. What about angulation?
I think you can discuss that in the tea break because you are running really short of time. Dr. Vijay, last talk he's going to discuss the distal femoral fractures in children, concepts in management.
Where is it? No, not this. Yeah, this is the last talk, this is a straightforward, simple one, small one. Distal femoral left facial fractures in children, they account for 6 to 9% of all facial injuries and far fewer than 1% of all fractures in children. So it's not very common. Typically you see it in the neonates and then you see it in the adolescents. You remember that in immature skeleton, it's the physis which will fail in tension first when the knee falls into valgus and varus. It's either a Salter 1 or a Salter 2 fracture typically. Pure compression injuries of the physis or Salter 5 fractures, though rare, have also been described. So this is what happens in an adult. You know that if you apply a valgus stress or a varus stress, your ligaments will fail and not the physis. There's no physis to fail. Whereas in a child, it's the physis which fails, and that's how you get these fractures. So displacement of the epiphysis occurs in the coronal plane. It either produces a varus or a valgus. You can also have anterior displacement of the distal fragment, which can be under the patella, or very rarely you can have a posterior displacement. Associated injuries, they are also known, ligamentous injuries and vascular injuries, though can occur, but they are very rare, unlike the proximal tibia where they are much more common. And a very uncommon injury is a peroneal nerve injury. Imaging, you have to have X-rays, of course. AP lateral is a must. An oblique view is very useful if you think that it's an entirely undisplaced fracture, because these are epiphyseal fractures and you have to put them back properly. CT scans are very useful again to study displacement, to figure out what kind of treatment you're going to do. MRI scans are useful in unclear cases. Okay, you can also use an ultrasound in the neonates, and that will rule out your septic arthritis. A lot of them will present you as septic arthritis. How do we manage them? We broadly divide them into neonatal, adolescent, depending on the displacement, whether it's coronal plane displacement, anteroposterior displacement, or the compression types, and then the complications. Close reduction, POB mobilization, the very minimally displaced fractures, and of course in neonates, we have to do close reduction and K-valve fixation or percutaneous screw fixation in the majority of fractures, those in the adolescents. Open reduction for the irreducible fractures. Remember, Do not hesitate to open, because again I stress these are epiphyseal injuries. Putting it back together perfectly will give the best chance for the physis to survive a damage. In all cases it is important to restore anatomy to minimize physeal damage. This was a newborn neonate, 3-day-old child presented with knee swelling, tenderness and cry on handling the limb. This was the X-ray. There was no fever. Lab tests were normal, commonly mistaken for septic arthritis, and there was no specific history of a difficult labor. And this was the X-ray. So this is again a distal femoral epiphyseal injury. You can actually see a small metaphyseal spike here. Treated with an arthrogram, okay, where you can see the valgus displacement. Simple close reduction, treated in a POP, and then went on to heal well, leaving no residual deformity. Adolescent corneal plane displacement, 14-year-old boy playing football. Remember, when you have a corneal plane injury, it's always a sports injury. It's a blow to the lateral side of the knee, develop pain, swelling and deformity, no distal neurovascular deficit. This is the X-rays he came with the typical classical displacement and the physeal injury. This is the type 2. Treated with simple close reduction, cross KY fixation. And then 3 months post-op they heal well, and because they're all closer to the skeletal maturity, you're really not too worried about early closure of the physis. Anteroposterior, these are high velocity injuries. This was in an RTA, sustained a close injury around the knee, no distal neurovascular deficit, and these are Salter-Harris type 1 fractures, where you can see that the distal fragment goes under the patella. These can be treated close rarely, where you put the patient prone, you give sufficient traction, you can reduce them, but in this case I had to do an open reduction, KY fixation. This is the older boy, so I put extra KYs, though not needed, pure immunization for 4 weeks, and then return to normal function in 2 months. Again, we're not worried, he's 16 years old, whether his physis closed early or not is immaterial. This is 4 weeks post-op. A compression type Salter-Harris type 5, which I spoke about, this is I showed it earlier. It's presented with a closed midshaft fracture, swelling in the ipsilateral knee. I aspirated the knee on table, got blood with fat globules, no fracture was seen on the X-ray, went ahead, did a 10 nailing, and this was the X-ray. The knee X-ray didn't show any injury at that point in time. 10 nailing done, knee brace for 3 weeks, and then she took a long time to recover knee range of motion, which is unusual for a straightforward fracture shaft. I should have thought of something, didn't think. 6 weeks later, X-ray showed good healing, and then you can see that something is happening around the knee. Slowly developed deformity of the knee. 15 months later, you can see the classical epiphyseal bridge and a growth arrest. So this was a type 5 injury, which is actually missed. Well, this girl later on had multiple osteotomies, lengthening, and now she's fine. But that is, it can be missed easily. CT MRI again showed the big bridge. This could not be excised, and then she needed various corrective surgery. Open reduction, this is from Dr. K. Wilkins, not mine. Again, an adolescent where you have a huge metaphyseal fracture, you can do open reduction and just fix the metaphyseal fragment. In this case, because it's more like a type 4 too, he's fixed the epiphyseal region too. Complications, recurrent displacement, well known. And remember, the use of fixation reduces the incidence of recurrent displacement. You have to get the anatomy right in these fractures because the physeal injuries, I re-emphasize. So these are all the a lot of literature has been written on it. Physeal injuries can cause progressive angulation, shortening in spite of fixing it well, and you can have missed physeal injuries. In conclusion, these are fractures involving the physis. They're particularly prone to complications and associated injuries. Physeal injuries may be permanent, will require long-term follow-up to monitor progression and to correct the deformity and the shortening. Surgeries to correct LLD and angular deformities may be required. In the adolescent, it is safer to fix the fracture than risk loss of reduction. At this point, I invite you all to IOACON 2014. It's in January between the 10th and the 13th. And it's in association with the Pediatric Orthopedic Society of North America. So we have faculty coming from there. So please do register. It's easy. You can register at IOACON2014.com. Thank you very much.
Thank you, Vijay. Again, the house is open for questions. Any question?
Nothing much. I would have warned the parents. I would have told the parents earlier. That's all. Huh? Because she had a healing fracture, which was missed.
The other thing I have seen in physeal injuries is that if you have physeal injury in the lower end of femur, it tends to produce more physeal bars. Then you have an injury in the lower end of tibia or upper end of tibia. For reasons which were probably because of memory bodies which are there in the
Memory processes, yeah.
But is that a normal occurrence
Yeah, I
you see as well?
think that is the cause.
Okay, so thank you Vijay, and I think we had a very fruitful discussion, and this the best culmination of this session would be by cases. The first case is to be shown by Dr. John Mukhopadhyay, followed by cases by Dr. P.N. Gupta. And we want this as an interactive discussion, please. So the faculty is not going to talk much. We'll ask you what you think or what the opinion of the house is.
Yeah, please.
Yeah, sure.
Completely displaced epiphysis, like post anteriorly. You fixed it up, opened it and completely closed.
Breakfast session.
You fix it up, you immobilize it, no flexion.
No, see, once you fix, they're actually, once you reduce it, they become very, very stable. Okay, and the only...
Immobilize in total flexion.
No, I didn't immobilize in total flexion. It was just immobilized with a simple... No. I said I put more wires than necessary. That's what I said. I'd put 4 wires, just 2 wires would have been enough.
Here's Dr. John.
Right, this is... oops. Yeah, okay. A 9-year-old girl who presented 1 month after this injury. Initial treatment was in a cast, and when she came, she had a totally stiff knee with just a jog of movement, and those were the x-rays. Any comments on the x-rays? Anybody?
Anyone can just please give comments to the x-rays. Yes, sir?
Yeah. Medial condyle, but is it the whole condyle or part of it, or physial injury involving parts? So it's like a Hoffa variant of a pediatric this thing. So it'll be a type what injury? Really a type 3 probably, yeah, but it's not. What type would this be, Dr. Shah Alam?
I would say a type 3. Type 3. It's not involving the...
Well, it is. It is.
Well, actually then we need better imaging on it.
Yeah, but there's still physis there. Okay, so we should look for better images.
Yeah.
Okay, so that's the one section of the CT. So part of the physis is involved, yeah? Okay, not the whole physis, but part of the physis. And that's the other CT, and those are the 3D reconstructions, okay? So certainly a part of, and there's comminution as well. Okay, and it's a 1 month down the line, and everyone says that after 1 week or 10 days don't touch physial injuries, but this is a situation where you really can't leave it alone either. Okay, so you obviously need to go and do something. So
now would they be in the group, someone in the group who would leave it as such?
9
years old and 1 month old injury, more than a month old injury. Anyone in the group who treat it conservatively?
Totally at this stage, totally stiff.
So everybody wants to do surgery, yeah? No conservatism in this patient? Any particular reason? Okay. So there's an intra-articular fracture. Intra-articular fractures you can't do without getting a 100% reduction.
But how easy is it to get a 100% reduction?
That's why we send it to you.
No. Quick heal. Yeah, so I think you have really no choice, so you have to bite the bullet here. This is at the table we could get it bent to about that much, not without anesthesia. That's at surgery, so you can see the clear step there.
Dr. John, what is the plan? Can you the surgical plan?
Plan was to more or less recreate the fracture and then reduce it and fix it. And how would you fix it? Anybody? So that's the step. If you see that, that's the kind of step from here to here. That's the displacement of that fragment. It's even worse than it looks on the X-ray or CT.
Yeah.
Yeah. No. But you could do it through the fracture. You didn't have to really, you could osteotomize it through the fracture. Yeah. So that was the first step. There was a lot of some callus here which had to be nibbled off. Nothing obvious, because you see if the ligament goes across here, it's attached here. So the ligament is actually spared because there's a posterior part of the condyle which is displaced, yeah? So you have to be careful not to injure it in your surgery.
Question is what promise you have given to the patient is how much movement she retains.
What promise do you think I could have given?
She had no movement. He said there was just a
At
jog
that
of
time, there was
movement.
literally a jog of movement. I think you have to explain all these things, the possibilities of growth arrest. But if you don't leave it, you have to kind of basically try and compare it what happens if you don't do anything. So there's no way they'd get movement. Yeah, so what you need to do is to do it anteroposterior, but because you'll be going through articular, you'll need to countersink the screws. So you can't actually leave it sticking out. So that was through the procedure, that's the osteotomy, you can see, to pull it out. Finally, we managed to get it down there. It's a slow, gradual process because you have to try and keep the soft tissue still attached to that fragment as far as possible. You can't just take it off everything and then bring it back. And then we used so we used screws from front to back, if you can see that. Where is that? Yeah. So these are the holes where the counter screws were put in from front to back, okay? That way. Okay, and then we show very clearly, not very clearly, but those are the screws from front to back on the lateral. It's unfortunate that X-ray is not showing so well on projection, but we were able to get a reasonably good reduction. We did leave it in a cast for a few days. Then we started range of motion at about 2 weeks, but at 6.5 weeks, that was all the movement she had.
Dr. John, why not a headless screw?
What size do you get headless screws in?
That is a problem, I know. I mean, but still, or maybe I don't know.
So what I use, you know the locking screws?
Yeah.
Okay, so they have a very small head. Okay. So you don't have to make such a big hole in the cartilage to get it sunk. So use the 3.5 millimeter locking head screws. And I use that regularly even for my adult fractures. Is instead of using the cortical or the canceller screws, I use the locking head screws because the head is much smaller, so you don't have to make a big hole in the cartilage to countersink it. So this is something I do regularly even in adults. So it's a useful thing to use and they work quite well. You can't truly compress.
Compression.
Not, but I mean you want to hold this, you can always compress with a clamp and hold it in that position. So this idea of having to do a lag screw to compress in an articular fracture is, you use your clamp to compress and you fix it in that position. Okay. You don't even need very much, but if you want, you use your clamp to compress and then you put your screw in that position. So it's fixed in a compressed position.
Very shallow threads.
So that's the advantage.
But shallow threads is less, very less purchase.
I know, but pediatric bone quality is so good. And the core diameter is another very important thing in screw pull out, okay? So there's, yes, the depth of the threads matter, but the core diameter is also a big issue in this. So when you have good core diameter, it gives you a greater surface area of contact. So that's another issue where, that's why they are more stable in a lot of ways, the shallow pitch, because you have a number of pitch and you have a bigger core diameter. So they give you a reasonable good thread. So that was at 6.5 weeks, we had only about 0 to 15 degrees of motion. So what do you do now? Wait. Okay. Injections? No? So we decided to actually do a arthroscopic arthrolysis at this stage because I think, yes, you could wait, but if nothing happened at 3 months, then it becomes tougher to do something later. So you take them to theatre and then do a arthroscopic arthrolysis. We were able to get almost full range of motion with the arthrolysis. This was at 4.5 months, okay, and this is at 1 year post-op. You can see she's maintained her alignment so far. Anatomically looks reasonably good, and that was the range of motion she was able to achieve. So I think it's worth trying in these, as long as, I think there's a situation where if you leave it alone, it's a helpless situation, then maybe you can explain the problems and then do something, and we really don't have literature to follow for things like this. I I don't think this is the only case I've done like this in my life, so I don't know how many of you have done cases like this. So you have to sometimes try and decide on the situation what is the best thing to do.
Absolutely.
It's difficult to draw parallels of what you would do next time because you don't see this situation at 1 month very often.
That's a fairly good movement. I mean, the kind of injury that she had and the late presentation.
Yeah. So
thank you.
Thanks.
Thank you very much,
Sure.
John. Thanks
Okay.
for that. I now request Dr. P.N. Gupta to present some of his cases, please. So there's a common, when he was asking us what type of Salter-Harris is this, there's a common mistake that, not mistake, actually you tend to forget the Salter-Harris classification. There's a kind of an acronym for it, so you remember the word Salter, S-A-L-T, don't remember E, just remember R, so S-A-L-T-R. So S is just slip, A is above, so there's a fracture above, then you have the L which is fracture lower down, T is through and through, and R is rammed, so type 5, so just don't forget. Just forget the E and then you have this. So easy way to remember Salter-Harris classification. Yes, Dr.
So that's
Gupta.
a case one. This 11 years old had this injury while playing, and that's the injury. And I want the interaction from the audience. What would you do in this sort of situation? Transcapitular wire.
Dr. Gupta, there's someone asking what is the range of movement?
This is a fresh injury. Fresh injury. So there's a reply that there's a taker for a transcapitular wire after close reduction, open reduction, or what? Open reduction and transcapitular. How many of the audience agrees with that plan? So quite a lot. So anybody wants to differ in this?
What do you think is
Close reduction?
just 1 second? What do you think is the risk of AVN if you do a open reduction in this?
Close reduction is difficult. It may not come.
True, but open reduction has a...
Yes, you can try close, then if it
If you are careful with the open reduction, you will not get
the
it.
gate camera and joystick.
Okay, this is extremely difficult to reduce close, but it completely falls off. That's been my experience. If it's difficult, 45 degrees, 60 degrees, it's okay. But it completely falls off.
There is a special technique described for this, but okay. And someone is saying something else over here, Dr. Gupta. Yes.
You can use a K-wire and just use the K-wire as a joystick to reduce it.
Okay.
With a
And the same K-wire can be used to fix it.
the potential to injury to the pin. So that's the only worry with that technique. Okay.
What about the Matazu?
So this is actually what we did. We used a K-wire to actually use like a lever, like a tire maneuver to reduce this head on top of the neck here, and then did a Matazu and pinned the thing in place. And yeah, you may not pin it, but we have been I have around 12 cases where almost every case is like displacement around more than 80 degrees, and we have used a wire to actually lever it onto the top of the...
You can actually use the titanium elastic nail to help you reduce the head. Okay, there's a technique
By rotation
described
of,
by you push it into the head, just impact it, and as you turn it, you can reduce the head with the rotation of the wire.
But this
you
sort
need to
of
partially reduce this with something.
this sort of situation won't be reducible.
That's what I'm
There's
saying.
too much of an angulation.
Yeah, you need to partially reduce it with close maneuvers, and then you
But
can...
what we did was a complete reduction on the Siam and
Yeah,
yes, you can make a hole. I'll show you the technique. You make a hole here.
That's now
Make a hole here.
Standard
Bend
technique.
the wire. Pass it into the intramedullary up till this place. Reduce the thing with whatever way you want. There are techniques to do the reduction. There are techniques to do a closed reduction. There are techniques to do an open reduction. I mean, with a leverage or a joystick, you can pass it. You can do a joystick also, and then hammer the wire across. And you can fine tune your reduction by your tip of the wire is bent a little, so you can rotate it this way and that way to fine tune your reduction. So that's the follow up. I think this is just an old slide, so the current follow up is basically more than 3 years old and there is no AVN. I have had about 12 such cases and no incidence of AVN. in any of the cases. So basically this is a Matthew technique and does minimal damage to the radial epiphysis. So this was a 8-year-old boy. Parents noticed a deformity in the elbow after a fall and a pain in the elbow. Patient was taken to a quack who bandaged the thing and massaged the thing, and subsequently patient ended up in a cubitus varus deformity, and he was shown to a local doctor who did a supracondylar corrective osteotomy, but the deformity was not corrected. And that is at presentation to us. The deformity is not corrected.
Just before you start discussing that, how many of you would operate on a cubitus varus in the first place? If there is a cubitus varus, child is 14 years of age or 12 years of age, how many of you will operate? No one will operate? No osteotomy? Oh, so majority will do an osteotomy, is it? How many will not operate on these patients? What is the indication for surgery in these patients? I really wanted to know this. As far as I am concerned, the only indication, so there is one hand. Please, sir.
Yes.
When the growth stops.
Yeah, I am saying 14 years. 14-year-old boy with a cubitus varus. Absolutely fine movement, no issues except for cosmetic deformity.
So why
you operate for cosmetic deformity, is it? So you guys do malpractice. Yeah, honestly. If you're operating for a cosmetic deformity, there are n number of cosmetic deformity that you should operate when the parents ask you to do. And that to a deformity which can be well hidden under your sleeve.
No.
Yeah.
Cosmetic deformity that a child asks for correcting.
Child never asks for correction. Well, never has in my career a child asked me for correction.
Child
Always
or
the parents.
Child party.
Yeah.